Hello, welcome to the 12 lead interpretation section of Apollo MedFlight's orientation. My name is Damon Crabtree. I'm the lead field training officer and a flight paramedic here at Apollo. Feel free to contact me anytime at my email or text or call me. I'm really available around the clock to help with any questions and guide you with any help along the way. For this lecture, we're going to start with a review of anatomy as it relates to the 12 lead EKG, go over a 5-step approach for evaluating each 12 lead you encounter. We'll discuss each step in detail. Then we'll discuss how to find different things on the 12 leads of different pathologies, disease processes, and then finally we'll do some application and practice. Number one, this should be second nature for most people watching this lecture, but the placement of the electrodes is vital for the interpretation and correctly interpreting at that. For our V leads, so our 6 leads that are going to go across the chest, we're looking to put V1 and V2 in the 4th intercostal space on each side of the sternum. V4 is going to be in the 5th intercostal space, mid-clavicular line. V6, still the 5th intercostal space, but mid-axillary line, and then V3 kind of in between V2 and V4, and then V5 in between V4 and V5. Most common mistakes are going to be placing V1 and V2 either in the 2nd intercostal space or the 3rd intercostal space, and that's going to cause the 12 lead to look like incomplete right bundle branch block whenever that pathology isn't present. And then also not putting V6 all the way at the mid-axillary line. That also is going to kind of mimic bundle branch block. This is a picture I always kind of keep in the back of my mind. So this shows you the angle that each lead is looking in at the heart. You're going to have your horizontal leads, which is the V leads, and then your hexaxial leads, which are the limb leads. The hexaxial ones, so leads 1, 2, 3, AVR, AVL, and AVF, they're going to cut the heart in half from front to back and kind of open up to where you can easily see both ventricles in the septum, and then your horizontal leads are going to kind of cut it in half top and bottom and give you a look around the heart kind of in a diagonal angle from V1 down to V6. All paramedics should have memorized this, day 1 of 12 leads in paramedic school. This is just going to help us identify which leads are associated with which part of the heart, and then furthermore, which parts of the heart are associated with what arteries. So you can kind of identify which artery could be occluded or at risk for occlusion. Lead 1 and AVL classically have been called the high lateral leads, along with V5 and V6, which are the low lateral leads. 2, 3, and AVF are the inferior leads. V1, V2 are septal, and then V3 and V4 are anterior. The most common arteries associated with each of those, the inferior wall is most likely to be supplied by the right coronary artery. V1, V2, V3, and V4 are usually supplied by the left anterior descending, and then lead 1, AVL, V5, and V6 would be the left circumflex. This is just kind of what it looks like actually on an anatomical heart. So you see that the inferior wall, which is highlighted green, comes off of the RCA, and then the large artery coming down on the right side of that heart would be your left anterior descending, which is supplying the light blue anterior wall and the purple septal wall. And then finally, hard to see on this picture, but the lateral wall is supplied by that artery coming off from the LAD called the left circumflex, supplying the pink area of the lateral wall. So this is my favorite thing to do whenever it comes to teaching people 12 leads in an in-classroom setting. I would give everybody a blank 12 lead with just the leads on it, with no actual electrocardiogram to be seen, and then I would ask everybody to draw a normal 12 lead, because most people don't have an idea of what it should look like on baseline, and that really hinders them from discovering what's abnormal whenever they're faced with a 12 lead that maybe isn't something they've seen very often. So what is normal? Foremost, we're going to look at the left 6 leads, so lead 1, 2, 3, AVR, AVL, AVF, and we're going to look for the P waves. So the P waves should all be upright, except for in lead AVR for those first 6 leads. They should be pretty small, well-rounded, not having a spike on either side. AVR should be the opposite of that, so AVR should be have a P wave that is inverted. V1 through V6, the P waves should start with either a positive or negative in V1, should be positive in V2, positive in V3, V4, V5, V6. The QRSs, starting again on the left side, you should have a decent sized R wave in lead 1, so mostly positive QRS in lead 1, mostly positive QRS in lead 2, 3, and AVF. AVL may have a positive QRS, or it could be half positive, half negative, so kind of equiphasic or isoelectric, which is terms we'll get into in a little bit. And then again, AVR should be opposite. The QRS and the V leads, you should have little or no R wave in V1. V2 should have a very small R wave. V3 should be where it transitions from the S wave being a lot bigger than the R wave to be about equal. V4 should be mostly R wave. V5 should be where the R wave is the biggest in all of the V leads. And then V6 should be just a little bit smaller than V5 without any S wave after the R wave. And then finally, the T waves, they should be positive in all the leads on the left side except for AVR. V1 can either have a positive or negative T wave. V2 should have positive, along with the rest of the V leads should all have positive T waves. It seems kind of self-explanatory, but you'd be surprised how many people I encounter that don't know what a normal 12 lead looks like, and I feel like without that good background knowledge, it makes it very difficult to interpret the 12 lead appropriately. So the 5-step approach, I didn't come up with this. This is based off of a lecture given by Amal Matu, who is a ER doctor and a whiz at electrocardiogram. So he gives 5 points to divide it up. It doesn't really matter what order you go in, as long as you're hitting every single point on every 12 lead. This one just seems the most intuitive to me. So we're going to start with rate rhythm. We'll determine the QRS axis. We'll assess all the intervals. We'll look for any sort of enlargement, and then finally we'll determine if there's ischemia present. Why the ischemia is at the end is we're going to want to identify any STEMI mimics or mimics of ischemia prior to that assessment, as opposed to people that have a 12 lead with left bundle branch block. They see ST elevation, ST depression, T wave inversions, and immediately think STEMI, and then activate the cath lab. They get to the hospital, and the doctor looks at it and says, no, this wasn't a STEMI, it's a left bundle branch block. If you go in this order, you should identify that stuff beforehand, and then know once you get to the elevation or depression measurement that, hey, I have left bundle branch block. Then I understand why those are already on there. Rate and rhythm. This should be intuitive. I'm sure all of us have identified rate and rhythm for thousands upon thousands of EKGs. For rate, there's a real simple tool that I like to use, and it's that one on the bottom there, the 300, 150, 100 method. The way that works is you look anywhere on your 12 lead or even a rhythm strip, if that's what you're looking at, and you find our big boxes and little boxes. So the big boxes are the ones with the darker pink or red lines, and then little boxes have kind of the opaque lines throughout and are obviously a lot smaller. The big boxes have 5 little boxes that make each one up, and if you're going horizontally, each big box is 200 milliseconds, and each small box is 40 milliseconds. So 40 times 5 equals 200. What you're going to do for this 300, 150, 100 method is we're going to find a QRS that lands on one of those big boxes, one of the bold lines. Once we find those, and it could be anywhere on the 12 lead, it doesn't have to be the first one that you look at, we're going to start counting. So let me get my little marker out here. So this one clearly falls on a bold line. We're going to count 300, 150, 100, 75, and then 60. And this ends just before 60. So we know that this rate is a little bit faster than 60 beats a minute. The second example, again, we find one that falls on the bold line, 300, 150, and it falls perfectly on that 150. So this rate would be 150 beats. And then finally, the third, find one with a nice bold line. It doesn't really matter. We could start with the second one and count backwards and go 300, 150, 100. So you just have to memorize these numbers, and they go below 60, but they're a little bit more difficult to assess rate whenever they fall in between at that slow of bradycardia. It would go 300, 150, 100, 75, 60, 50, 45, 38, 33. So it's not extremely important to be, right on the money that it's, 74 beats a minute or it's 155. We're really just trying to get into, what category is it in? Is it really fast? So is it over 150? Is it just sort of fast between 100 and 150? Is it normal, 60 and 100? Or is it less than 60 and is bradycardia? The 300, 150, 100 method is great for our regular rhythms, but you could imagine that once it starts getting irregular, so like an atrial fibrillation, you're going to have varying rates. So it gets a little bit less accurate and harder to determine. Honestly, I just still use it. And so, say that all these rhythms were connected down here, and it was just one EKG, and I would go and I would say, okay, well, this one has a pretty large gap. At this point, the rate's about 60. Over here, it gets real fast, and it's 150, and then finally, this one's about 100. So that would be atrial fibrillation with, very variable conduction between 60 and 150. Alternatively, there's 2 other methods. You could do mathematical, which is a little bit confusing. You would count the number of boxes in between each R wave, and then it would be 300 divided by 1, 2, 3, 4, 5, and that gives you 60 beats a minute. So not really that hard, but most people don't take the time to memorize that. And then the 6-second method. So our monitors will print out a rhythm strip, so the LifePak 12, right whenever you put them on the 12 lead, should be printing out a rhythm strip that's 6 seconds long. But if you just press print throughout transport, it's just going to print until you stop it. So unless you have a watch and you're perfectly timing it, you're not going to get a 6-second strip. And the way you can get past that is you would just count the number of big boxes on your strip, and you'd count out to 30, and that's going to be 6 seconds. And then you just count the number of QRSs in that range that you kind of marked off, times it by 10, and then there's your rate. Next part of this rate and rhythm is obviously identifying the rhythm. This PowerPoint's not going to go into the interpretation of each specific rhythm. You should be coming in with a baseline knowledge of all these different rhythms and what criteria it is that makes each one up. Your main ones are going to be the ones that I put on the screen. So normal sinus rhythm, your sinus bradycardia, sinus tachycardia. junctional rhythms, atrial fibrillation, atrial flutter, idioventricular, different types of paced rhythms, VTAC, and then sinus arrhythmia. Just be aware that there's several more out there, such as Wolff-Parkinson-White, multifocal atrial tachycardia, all your different types of SVTs, a couple different types of bradycardia, obviously all your different blocks. That would take, another hour or two. So if you don't have a good working knowledge of all these different rhythms, then please go do some additional studying. If you don't know where to go find that, shoot me a text or an email and I'll get you some links to go learn some rhythms. Your second point is going to be axis, and this is probably the most daunting of the assessments that you're going to do for the 12 lead. But honestly, it's not that hard. It's just some memorization of numbers and lead placement, and then pretty simple steps. So in order to determine axis without the 12 lead telling you what it is, which is kind of the whole point of this method, is to not rely on the 12 leads, computer interpretations. They're great. I use them all the time. But if you don't know where those numbers came from, then I feel like you don't have a really good understanding of what's going on in the 12 lead. So something to do if you don't have axis determination already memorized is to draw this circle. I've probably drawn it, 100 something times. Where I'll draw the circle and I'll start off with an X. And from that X, I'll start branching out. So I'll draw my circle, and hopefully it's a lot neater than this. I'll draw my X. And I'll start with 0. So for whatever reason, just based off how the heart axis is normally conducting, they place a 0 out here on the right side for starters. So it goes 0 all the way around to 360, but in order to make an easier assessment, instead of having the larger numbers out here, they just go negative backwards to 180. So I'll start with 0 and I'll label 0, and I know that 0 is where lead 1 sits. So lead 1 sits out here at 0, and imagine that my heart's sitting in the middle of this. Lead 1 is looking out here at this lateral wall. Hopefully you guys can understand what I drew right there. So everything that's sitting out here on the circle is looking in from that point. So lead 1 is looking at the lateral wall. Well, my other lateral lead for the hexaxial leads, which is 1 through 3, and then ABR, ABL, ABF, is ABL. And so ABL sits here at negative 30, and if it's looking in, it's also looking over here at this high lateral wall. So ABL is associated with negative 30. If I go down just to the bottom, I get to 90. So I would label 90 right here. And 90 is associated with ABF, which is one of the inferior leads. Well, out to each side of it, there's my other 2 inferior leads. So out here at 120 degrees is lead 3, and then out here at lead 2 is around 60 degrees. So all 3 of these are looking at the inferior wall right here. Finally, so based off my hexaxial leads, which there's 6 of them, I have 1, 2, 3, 4, 5. So I have 1 more lead, and it's ABR out here in no man's land. So what ABR is looking at is it's looking at the base of the heart, so kind of where the atria connect to the ventricles. Most people end up disregarding ABR from their 12 lead interpretations, mainly because they just haven't been taught what ABR actually means. So there's a lot of literature out there that shows that ABR can help determine if the patient is going to need bypass surgery whenever they're having a STEMI. The reason for that is ABR, again, is looking at the base. Well, what comes out of that base? The aorta, and off of that come our coronary arteries. So if you have a left main disease process, AVR is looking directly at that left main, and you're going to see ST elevation in AVR whenever there's left main disease. So that seems like a lot, but just please go draw the circle on a couple blank sheets of paper, memorize 1, 2, 3, AVL, AVR, and then AVF down here. And eventually you'll just associate those with the different numbers. This is probably my favorite picture for axis determination because it puts as close to a real heart as possible along with the hexaxial and the horizontal axis. So this has all the leads and it clearly points to where each lead is looking. So again, like I said, starting out with AVR. AVR is over here looking at the base, and right here the aortic root and the coronary arteries come off. So that's where AVR is going to have a lot of use. Lead 1, looking out here at this circumflex coming off the lateral wall, along with AVL. So also looking at that circumflex. 2, 3, AVF, looking down here off the inferior wall. 2 is almost pointing perfectly at the apex of the heart, but that's normally still perfused out here by the right coronary artery. And then what we don't use for axis determination, but still a really good idea to kind of have memorized where they're exactly sitting. V1 and V2 are looking at the septum. V3, V4 looking at the anterior part of the heart. And then V5 and V6 are over here looking at the lateral wall along with 1 and AVL. There's also posterior leads, so V7, V8, V9. If we put those leads around the left side of the patient, we'll be looking at the posterior wall. V4R would be looking over here directly at the right coronary artery, which is going to perfuse the right ventricle. All right, so here is a 12 lead that's superimposed on that circle that I've drawn. So I draw my circle and then I just kind of leave out everything that isn't directly on the 12 lead. So there was several different points on that circle earlier, and all that was the negative leads. So lead 1 right here at 0 is the positive interpretation of lead 1. Well, there would also be an opposite out here, negative lead 1 at 180 degrees. But that's not something that's easily shown to us on our 12 leads, so we just leave it off for the most part. But you'll see in the next slide how useful it is to try to view it as a full 360-degree view of the heart. So just kind of looking at this, I look down at 2, 3, and AVF, and all of them have pretty large T waves relative to the Q or S size and pretty subtle ST elevation. Lead 3 and AVF have enough ST elevation out here to call a STEMI. So this is a subtle inferior STEMI. Anytime you have an inferior STEMI, you'd want to look for reciprocal changes. Well, the best lead to do that is if I'm looking out here at lead 3, which has my maximum amount of ST elevation. So I'm trying to draw that for you. So about 1 to 1.5 millimeters of elevation along with my biggest T wave. If I look completely opposite that, negative 3 would be right here. Well, I can't see negative 3 on a normal 12 lead, but I can see AVL, and AVL clearly has ST depression and a T wave inversion. So this is what that looks like with all those negative leads superimposed. And what's really cool is you can actually see the ST elevation or just the ST deviation get bigger and smaller all the way around the heart. So again, I said lead 3 had the maximum amount of ST elevation right about here, where you would measure ST elevation compared to about right here. If I just move clockwise around, my ST elevation is less right here, minimal right here, isoelectric, and then it starts getting negative out here, negative maximum amount because it's completely opposite of lead 3. So you have the maximum amount of ST depression, and then AVL, which we said is our best lead for reciprocal changes. And then it starts becoming isoelectric again, and then our elevation begins to come back up. And that works for your P waves, your QRSs, and your T waves as well. So lead 3 has the biggest T wave on here. Out next to it, negative AVL, a little bit smaller, starting to be negative in AVR, clearly negative in these top 3 negative leads. AVL has a good amount of ST depression. That's why it's such a good reciprocal lead for an inferior MI, and then back around where it starts getting positive again. The QRS, let's see, is most positive in lead 1 probably, and it begins to get more and more equiphasic as it goes around. ABF, it's almost pretty well negative, but a small negative QRS, a little bit bigger negative QRS in lead 3, and then completely negative in lead negative 1. All right, so very important to have our circle memorized so we're able to really look at each lead and determine how it's affecting the heart and what it actually means in each of those leads. So what we're going to do to determine the axis, so actually find the number value for the axis of the heart, 3 steps. First, we're going to find the isoelectric lead, and this is all determined off of the left 6. So 1, 2, 3, AVR, AVL, AVF. That's all we care about when it comes to axis determination. So we'll find which one of those has the isoelectric QRS lead. Next, we'll find where the positive leads are grouped. If we think back to where it was grouped by inferior, lateral, etc. And then we're going to calculate the QRS. So here's example 1. The first step was to find the isoelectric lead. What that means is which lead is smallest when it comes to the QRS. So on this one, that's going to be AVF. So AVF has a tiny little QRS that has a little bit of a negative dip and then a little bit of positive dip. So this is the lead that I'm going to call isoelectric. If I remember correctly, AVF sits at positive 90. I'll go ahead and just label all of these so everybody can start memorizing it. 1 sits at 0, 2 sits at 60, 3 sits at 120, AVL sits at negative 30, and then AVR sits at 210 or negative 150, which either is the correct answer. They're the same thing. It just determines on if you carry out the negative numbers into that extreme right quadrant. So AVF is my isoelectric lead. It sits at 90, so that means if I draw my little circle, it's looking up from here at the bottom. My next step was to find my positive leads, or easy enough is which lead has the tallest R wave. If I look at these 6 leads, lead 1 has an R wave that's roughly 12 millimeters tall. So that's going to be lead 1. So that means that my QRS axis is pointing towards lead 1. It doesn't have to be perfectly at lead 1. It just means it's pointing somewhere over here at lead 1. So it means that my discharge is mostly horizontal from the right side of the heart to the left side of the heart, pointing this way. And then third is to calculate what our QRS axis is. What that is the QRS axis is 90 degrees off or perpendicular to this isoelectric lead. So my isoelectric lead is ABF, which sits down here at the bottom of the circle, and it's 90 degrees off of that. So that could be either 180 or it could be 0, where lead 1 sits. And you have to determine which one is the correct answer. Well, the correct answer is going to fall where my most positive R wave was, which was lead 1 out here. So the QRS axis for this 12 lead is 0 degrees. And which we'll show you in a minute, that falls within the normal limits for QRS axis. All right, so here's a second example. This one gives you all 12 leads on it, but remember, we're going to ignore these other 6 because they don't determine axis. They tell us a bunch of good stuff, but nothing for this, so ignore all these leads and just focus on our last 6. Again, we'll start with finding the isoelectric lead, which for this 12 lead is going to be lead 1. Lead 1 sits at 0. Next, we're going to find our most positive QRS, which looks like for this would be any 3 of these. All of them have about an equal R wave, which these are all grouped as the inferior lead, so we know that it's going to point down towards the inferior lead. So if I draw my circle again, my little X in it, lead 1, 2, 3, ABF. All these are positive down here. So that means that my QRS axis is pointing downward towards the heart. So step 1 was finding my isoelectric lead, which is lead 1 since it's 0. Finding which leads are most positive, which are these down here. And then my QRS axis is 90 degrees off of this isoelectric lead. So it could either be negative 90 or positive 90. And the answer is which ones the QRS is pointing to, which is down here. So the answer for this 12 lead is positive 90, which kind of falls right on the edge of normal. One second. PowerPoint froze on me. All right, well, let me just get back real quick. It looks like my PowerPoint deleted one of my slides. I'll just use this real quick to help draw. I said that there is different quadrants to determine kind of where our QRS axis falls. So if I draw my little circle with my lines, 0's out here, 90's down here, 180. Excuse my writing. And then negative 90. Well, for normal axis, Normal axis is going to sit from negative 30 down to 90. That's normal. Right axis deviation is going to be from 90 over to 180. So RAD. Left axis is going to be from negative 30 to negative 90. And then extreme RAD, so extreme right axis deviation, is out here in no man's land, also known as the northwest axis, and that's 180 to negative 90. So out here is where people kind of have an argument about what to label this number-wise as. It could be negative 90 out to negative 180, or it could be 180 out to 270. So no, there's going to be several different interpretations. You can find this little circle online that just breaks up each quadrant by its criteria. And we'll get some more practicing with that when we get to the examples at the end of this PowerPoint. So we did rate and rhythm. We're going to determine the axis of the QRS. And then the third step is for intervals. So we're going to go through and evaluate all our different intervals. So this graph has all our different intervals labeled, along with showing us how big each big box is and how big each little box is. The big ones are going to be your PR interval, your QRS, and then your QT. Your PR interval should be 120 to 200 milliseconds. That's measured from the beginning of the P wave to the beginning of the QRS. If it's shorter than 120 milliseconds, that's a short PR syndrome. The most common is going to be Wolff-Parkinson-White. If it's longer than 200 milliseconds, pretty much the only thing that's going to do that. There are different heart blocks, and the one that's consistently always over 200 milliseconds is the first degree AV block. Next, your QRS interval for adults should be less than 120 milliseconds. That's 3 little boxes wide. If it's less than that, it's normal. If it's over that, that's a wide QRS, and that might be due to bundle branch block or ventricular or paced rhythms. Then third is our QT interval. That's measured from the beginning of the QRS to the very end of the T wave. And these don't have strict numbers for criteria. I'll show you a little method in a sec to determine what's too long. For men, they say normal is going to be 350 to 440 for a corrected QT, so you'll see QTC, and women 350 to 460. The reason that it has to be calculated as a corrected QT interval is because as your heart gets faster, the shorter your QT gets, and as it gets slower, the more drawn out it is. So they have to factor in heart rate to give a determination that we can actually compare to. Other types of intervals would be like PR wave, or P wave duration. So if your P wave is really, really long, that's something that you'd want to notice because there's different P wave pathologies. If your P wave is really long, that's also going to make your PR interval really long as well. You're going to look at how long your ST segment is. Sometimes your ST segment can be really short. Sometimes it can be extremely long, which has different kind of differentials for it. And then T waves are going to do the same thing. This is kind of the one spot that I don't really commit a lot of memory to memorizing these formulas. I do want you to be able to look at a 12 lead and kind of rip off the interpretation, be able to tell me everything about it. But QTC is pretty difficult. It takes a little bit of math and determination on how to actually calculate the QTC, and even that, the Zatz formula is the most simple one, so it's the most inaccurate as well. The best way to determine if your QT interval is too long, is this poor man's version of QTC. So what you're going to do is you're going to find two R waves. So the R wave that I marked is right here, and then right here. And then you're going to draw an imaginary line from R wave to R wave. After that, I'm going to find a line directly in the middle, or I'm going to draw a line, directly in the middle between those two R waves and cut it right down the middle. And then if my T wave, which starts about right here and ends about right here, my T wave ends after this imaginary line I drew, then my QTC is too long. So I'd have to start looking for reasons why my QT is prolonged. Hypomagnesemia, hypokalemia, hypocalcemia, a couple other things cause it. And I would be worried about polymorphic VTAC or like something like torsades happening, because the longer my T wave gets, the more likely I'm going to throw a PVC on top of that T wave and put them into some sort of dysrhythmia. All right, so we did rate and rhythm. We looked at axis. We looked at all the different intervals, and then we get to enlargement. So the main ones that we're looking for here is left or right ventricular hypertrophy. You can also look at left and right atrial enlargement. And then I just lumped low voltage in here because you'll see I'm going to be measuring QRSs and see how big they are to look for the different ventricular hypertrophies that I'm going to be able to identify whenever there's low voltage as well. So for LVH, the most common criteria is going to be looking at V2 and then V5 or V6, whichever one has a bigger R wave. Lead V2, I'm going to count all the little boxes of the S wave. So V2's S wave plus V5 or V6's R wave. You're going to add all those little boxes together from each one of those. If it's over 35 millimeters, then that's LVH. Most common criteria. Other criteria is if any lead on the 12 lead is greater than 35 millimeters, which if you look at V5 is greater than 35 millimeters. That's LVH, but a lot more non-specific for LVH. The most sensitive and specific criteria would be looking at lead AVL. And if lead AVL's R wave is greater than 11 millimeters, that's LVH. Next, you're going to look for RVH. And so RVH, you only have to look at one lead, and that's going to be lead 1. And the criteria for that is an R wave that's greater than 10 millimeters, which isn't the case in this example, or an R to S ratio greater than 1. And all that means is that your R wave is bigger than your S wave. Some other stuff that we can look in this section is going to be that left and right atrial enlargement. Left atrial enlargement, we're going to be looking in either lead 2 or V1, and there's just different shapes. The easiest way to find left atrial enlargement is if the P wave is greater than 3 boxes. So that would be greater than 120 milliseconds, which would be a really long P wave. And usually it has 2 little humps. In lead 2 or in lead 1, it would be a positive P wave followed by a negative end of that P wave that dips below the isoelectric line. Left atrial enlargement by itself, it doesn't give a lot of information. Most likely it's going to be accompanying LVH because what's happening with left atrial enlargement and left ventricular hypertrophy is there's some blockage beyond that ventricle or beyond that atria. So with LVH, the most common thing that's going to cause LVH is going to be systemic hypertension. So you have a clamp down aorta and systemic side, so really high SVR, and that ventricle has to get bigger and bigger to try to pump against that high amount of resistance. So that's how you get hypertrophy, is it has to bulk up because it's pumping against all that resistance. Well, same thing is going to happen with left atrial enlargement, is something's going to be blocked or hard to pump past beyond that left atria. So you look at the left atria, below that is the mitral valve, and below that is the left ventricle. Well, if you have LVH and that's all enlarged and pumping in efficiently at that point, well, it's going to create back pressure through that left atria and cause it to also get big. Other things that cause like the left atrial problem is like a mitral valve regurg. So if that mitral valve isn't opening appropriately, it's going to be harder and harder for that left atria to pump. And then same thing with the left ventricle. If you had an aortic valve problem and you couldn't get the blood out of the left ventricle, then it's going to cause it to bulk up. Same thing's true for the right ventricular hypertrophy and then the right atrial enlargement. So most common thing for RVH is going to be pulmonary hypertension or PE. It's going to cause blockage in one of those pulmonary arteries, which makes it harder to pump against for the right ventricle, and it's going to make it bulk up. Low voltage is defined as QRSs that are less than 5 millimeters in lead 1, 2, or 3, or QRSs that are less than 10 millimeters in lead V1, V2, or V3. And so it can be either or. So you can either have the criteria met for 1, 2, and 3, or the criteria met for V1, V2, and V3, but they have to be less than that cutoff in all of those leads. So if it was for lead 1, 2, and 3, they would all have to be less than 5 millimeters. And if it was for V1, V2, and V3, they would all have to be less than 10 millimeters to meet that criteria. What causes low voltage is going to be anything that's in between your electrode on the chest or out there on the extremities and the heart. So COPD is going to have a hyperinflation of the lungs. You're going to make it more difficult for our electrodes to pick up the electricity of the heart. Pleural effusion, pericardial effusion, cardiac tamponade, obesity are all going to make it harder and harder for the leads to pick up electricity. So finally, we get to the ischemia section. So hopefully, building up to this point, we looked at rate rhythm. So there we would be able to identify if it was a paced rhythm or ventricular tachycardia. We looked at axis, which in a little bit you'll see different differentials for that. We looked at intervals for different problems. We assessed for enlargement, so we would determine if there was LVH or RVH. And finally, we're going to do a really good assessment on our ST elevation, depression, T wave inversion, hyperacute T waves, Q waves, and then poor R wave progression. A lot of paramedics in school were kind of just taught, hey, this is ST elevation. That's a big deal. So if you ever see ST elevation, start treating aggressively and get them to the hospital rapidly so they can go to cath lab. But they weren't taught the different STEMI mimics. So our STEMI mimics are going to be left bundle branch block, left ventricular hypertrophy, paced rhythms, left ventricular aneurysm, benign earlier polarization. There's a couple lesser known ones that are out there. So this entire 12-lead interpretation strategy is in order to find all that stuff before we start assessing for ischemia. So to look for our ST deviations, we have to know at what point to measure. So the first thing we do for ST measurements is we're going to find the J point. And the J point is when the QRS transitions from being nice, sharp, down or up, down, or whatever it is. So nice, clean turns to start leveling off. So our J point is right here for this side. and you don't measure the ST elevation at the J point, you're going to measure a box and a half over. So this is falling right on one of these lines. So right here is a box and a half. And this is where we're going to measure ST elevation. We have to have something to compare it to. So we're going to use the isoelectric line, which is between the T and the next P wave. So that's going to be right out here. So I'll do this on my 12 leads whenever I'm trying to determine exactly how much elevation there is. So I'll draw that line all the way out from the TP segment down underneath where I marked to measure. And then I'll just count. 1, 2, 3, 4, 5, 6, 7, 8. So this is 8 millimeters of ST elevation. Please use the TP segment. It's the only true isoelectric line on 12 lead. A lot of people are used to using the PR, which is kind of easier to see, but there are cases where you're going to have PR depression. And if you had PR depression, it would look like you had, for this, it would look like you had 9 millimeters of ST elevation as opposed to 8, which isn't a big deal, but whenever you're looking at like a subtle inferior line, if you had PR depression and then just a tiny little bit of elevation, it might look like it meets criteria for STEMI whenever really you're just reading it off of the wrong line. So for this example of ST depression, again, we're going to find where it moves from nice and sharp to more of a prolonged transition. So that's going to be probably right here at the bottom. And then we move a box and a half over, which is about right here. And this is what we're going to measure off of, or my isoelectric line. I'm going to draw across and then just count 1, 2, 3. So there's 3 millimeters of ST depression. Next, we look for T-wave inversions. So there's kind of benign looking T-waves, which would be small inversions. Those are kind of non-specific. So if I had like a QRS like this, and then I had just a tiny T-wave, that's not as big of a deal. It might tell me something, but it also might be benign, as opposed to this, which has a nice symmetric T-wave inversion. These are always going to be bad outside of AVR and V1. So we'd want to find any T-wave inversions on the 12 lead and determine if they're deep symmetric or small. You can also have T-waves that are really large that drop below the isoelectric line before they end. So QRS right here, which my drawing's not very good. So QRS, and then a T-wave that's real big, and then it even drops below and it's negative for a bit. These are called biphasic T-waves. And biphasic T-waves are usually a sign of true ischemia. There's a syndrome out there called Welland syndrome that really gets into these types of biphasic T-waves. Next, hyperacute T-waves. So sometimes the T-wave is just too big in comparison to the QRS size. There's not a really strict criteria of how big is too big. Most literature thinks that 35% is too much. So that means 35% compared to the QRS. So that means that if this was 10 millimeters in height, and this was 15 millimeters, 10 divided by 15 equals 66. So that's over our cutoff of 35%. So that would be a hyperacute T-wave. Some stuff of a little bit lesser importance after you look for ST deviation and T-wave inversions. we're going to look for Q waves. So a pathological Q wave is going to be one that's bigger than one little box in width. So in this first example, this is about one box wide, so this is a pathological Q wave. So that means that this part of the heart is dying off. So this is a Q R wave, the little Q, big R, because it's a little Q and a big R. So say this was lead 2. Lead 2 sits at 60 degrees. So whenever the ventricle is depolarizing at the very beginning, what lead 2 is looking at isn't getting any electricity to it because part of lead 2 is dead. So it's not getting any discharge towards it. It's only getting discharge away from it at the very beginning of its depolarization. And then eventually it gets some conduction from some neighboring myocytes. And finally it gets an R wave. So part of lead 2 is still alive, but part of it is definitely dead. What's worse is this QS wave. So all this is just a negative QRS, so it has no positive aspect. So say if this was lead 2 again, it means that lead 2 sitting at 60 degrees isn't getting any conduction to it. So all of that section of the heart is dead because it doesn't have any positive aspect to the rest. That's sort of associated with this poor R wave progression. So due to how the V leads are looking at the ventricle, which all the V leads are looking at the left ventricle and the septum of the left ventricle, and they're pretty close to it. You know, they're sitting right above the heart. So you should have really good R waves from V3 on in all 12 leads that don't have damage to the heart. It's really hard to develop Q waves in V1, V2, and V3 because of how big that left ventricle is. It should be getting a huge amount of electricity towards it normally. So poor R wave progression is defined as an R wave in lead 3 of less than 3 millimeters. So if I look at this 12 lead, that has about 1 millimeter of an R wave. So that's not a normal size R wave for V3. So this is poor R wave progression, which is kind of similar to Q waves. Since it's so hard to develop Q waves in the anterior leads, what's going to happen before those Q waves develop? So if you did have an anterior MI, since that ventricle is so large, it's going to knock down the R wave size in V2, V3, and V4. If it gets really severe, then it will develop QS waves, but that's just really hard to do based off of its size. All right, so those are your 5 steps. It's going to be rate and rhythm as one, axis, intervals, enlargement, and then ischemia. The whole point is to get to these differentials, so to identify that you have certain things on the EKG and then figure out what's causing it, to know if it's a critical need for intervention or if it's an old pathology, or if that ST elevation on the 12 lead actually means occlusion as opposed to something that's, you know, a little bit less benign. So we'll talk about the different types of deviation. So the differential for radix deviation is right here. It has several different things that could cause right axis deviation. And remember, right axis deviation is going to be anything in this bottom left quadrant. So that's from 90 to 180. So right here. And just try to remember how my heart's sitting. out here. So a normal discharge, you should have a discharge towards like lead 6, like lead 2. So your heart should be normally discharging in this fashion. With right axis deviation, instead of it going down here towards the apex, which should normally happen because you'd want it to conduct down through the bundle branches out to the Purkinje fibers and then have the entire ventricle collapse upward, pushing the blood out. For right axis deviation, it's pointing towards this quadrant. So it's pointing more so towards the right ventricle, which is ineffective for left ventricular pumping. So what causes right axis deviation? So right ventricular hypertrophy. So if this right ventricle is ballooned out and huge, it's going to pull more and more electricity towards it. RV strain is kind of a collection of different things that happen whenever there's pulmonary hypertension or PE. So it's going to kind of be like bundle branch blocks and T-wave inversions out there. That's just going to pull the heart towards the right ventricle because it's strained. Lateral MI is whenever you have an old lateral MI, so you have Q waves and lead 1 and AVL. If you look at 1 and AVL, lead 1 sits at 0, AVL sits at -30. If they have Q waves in those leads, then it's going to, instead of discharging out here towards those leads, if they have just negative QRSs, it's going to put the axis somewhere out over here. Chronic lung disease is going to do kind of the same thing as right ventricular strain. It's going to make it harder and harder for the right ventricle to pump. So like in COPD, you're going to have hyperinflation of the lungs, and that's going to compress those pulmonary arteries and make it harder for the ventricle to pump into those pulmonary arteries. Hyperkalemia is what Amu, one of the main guys I got these concepts from, calls the syphilis of electrocardiography. The reason for that is syphilis used to always mimic, low blood sugar, Alzheimer's, chest pain, stroke. Hyperkalemia does the same thing for EKGs. It can produce right axis deviation, ST elevation, T wave changes, P wave changes, bundle branch blocks, heart blocks. So hyperkalemia, you're going to see pops into a lot of these different differentials. Sodium channel blockade does kind of the same thing as hyperkalemia, and it pulls the heart towards the right. Wolff-Parkinson-White. So Wolff-Parkinson-White is what I said is coming from like that short TR interval. And the way that happens is it's bypassing the AV node. So Wolff-Parkinson-White, you have some sort of pathway outside of the AV node, so coming from the atria to the ventricle, what is commonly referred to as a bundle of Kent. And so since it doesn't have to go through the AV node, which the AV node usually sits and holds the conduction for a moment so the atria can contract and fill the ventricles, that doesn't happen in Wolff-Parkinson-White. It just goes straight through, and it causes a wide QRS because once the impulse comes from the atria, bypassing the AV node into the ventricle, it just moves myocyte to myocyte across the entire ventricle, so causing a wide QRS. So you can have right axis deviation if it innervates the ventricle from the right side. Dextrocardia is where the heart is flipped in the chest along with the other organs. So if you had dextrocardia, then the left ventricle would be on the opposite side. So left ventricle being bigger would pull more electricity towards the right side of the EKG. Ventricular rhythms can arise from anywhere in the ventricle. So if it's arising on the right side, then it's going to pull it towards the right side. So different atrial septal defects will cause it. Most pediatrics are going to be around 90, maybe a little bit beyond 90, until they grow a little bit and their heart starts to level out. Because whenever they're born, their right ventricle is very forward towards the sternum, and as they get bigger, it starts to flatten out within their body. And then finally, left posterior fascicular block, which I know in paramedic school I was taught that right axis deviation means left posterior fascicular block. And if you remember the old kind of cheap way to do it would be you have a lead 1 and you determine if it's positive or negative. So for left posterior fascicular block, lead 1 would be positive, and then lead 3 and AVF, lead 1 would be negative, so pointing down, and then lead 3 or AVF would be pointing up, and that's left posterior fascicular block. Well, it's not that simple. You have to roll out every other one of these differentials before you can call it left posterior fascicular block. And usually left posterior fascicular block is about 90 to 115 degrees. So it's kind of only in a certain section of right axis deviation. Next differential is your left axis deviation, which is a little bit easier. There's not as many on here. Draw my circle, draw my heart, which each time it keeps getting worse and worse. I remember left axis deviation is going to be negative 30 to negative 90. So my normal heart would be usually pumping somewhere in this direction when it comes to the discharge. But for left axis deviation, instead of going down to the apex, it's coming out here somewhere, which is inefficient since the bulk of our ventricle is down here. So what's going to cause that? So LVH could cause it. Just because you have left axis deviation doesn't mean it's LVH, and you can have LVH outside of left axis deviation as well. Left bundle branch block, same thing. Inferior MI, kind of the same thing as the lateral MI was for right axis deviation. So in school, I was taught, okay, if lead 1 is up, lead 2 is either down or equal, and then lead 3 is down, that was left axis deviation, and that meant left anterior fascicular block. Not the case always. As you see down here, it's at the bottom of my differential. So why would inferior MI, so old MI with Q waves, cause this left axis deviation? Well, because 2 and 3 are inferior leads. So if they both have QS waves in them, then that's going to look like left axis deviation to us. Again, ventricular rhythms, if they're rising over here in the left ventricle, that's going to cause left axis deviation. Wolff, Parkinson, White, same thing. If it's coming down the left side, they could cause it. A different type of atrial septal defect can cause these issues. And then finally, it's that left anterior fascicular block, which has a strict criteria of negative 45 to negative 60. So just because it's left axis deviation doesn't mean it's left anterior fascicular block like most of us were taught in school. The easiest one is extreme axis deviation because it only has 3 components to the differential. All right, so our extreme axis is going to be this quadrant out here, which is opposite from what our heart should normally conduct its electricity towards. What's going to cause that? So if you have a ventricular rhythm, it can cause extreme axis deviation. Hyperkalemia can pull the axis all the way back over here. And then severe right ventricular hypertrophy. So if your right ventricle gets large and it's pulling all of the electricity towards it, eventually it could cause deviations out here into the extreme area. The reason it's so simple is ventricular rhythms. Most of those patients are going to be obvious. They're going to be your cardiac patients, patients with weird pacemaker placement. Pretty easy to identify. Hyperkalemia, you're going to look at them with just your history of present illness and your assessment. So they have a history of renal failure, diabetes, benign prostate hypertrophy, and hypertension. Then they're at risk for hyperkalemia due to the renal failure. And then RVH, those patients are probably going to have a known history of unresolved PE or severe COPD with decompensated heart failure, that they're not even going to be able to stand up and walk 5 feet on a normal basis without being short of breath. So you should be able to pick that up in your history section. ST elevation, so not everything is a myocardial infarction. Obviously, that's at the top of our differential, what we're going to have to explore first, but could be just coronary vasospasm, which is going to present exactly like myocardial infarction. Pericarditis, so an inflammation of the pericardial sacs, is going to irritate those coronary arteries and going to make it difficult for them because they're going to be inflamed. So that's usually going to cause pretty mild and widespread ST elevation. Benign earlier polarization is common in young African American men, where their heart just has huge QRSs, kind of like in left ventricular hypertrophy, but not due to a hypertrophy. Biggest thing to remember for that, and really applies to all 12 leads, is the bigger your QRS is, the more likely you're going to have ST deviation in the opposite manner. And we'll talk about Scarborough criteria in a little bit, and that is pretty evident. Left bundle branch block, so the wider your QRS gets, also causes more likely for ST deviations in the opposite way. So left bundle branch block causes a wide QRS, so it's going to cause ST deviations. LVH also causes widening and really big complexes, so you're going to have both of those kind of added in together. Ventricular aneurysm is whenever that ventricular wall has died off due to an old MI, and now it's just ballooning outwards. So it will look like ST elevation, usually mild 2, 3, maybe 4, without huge T waves that usually come with STEMI. Brugada syndrome is pretty interesting pathology that's common in Asian cultures, and it's a cause of sudden death. So if it's not identified at a young age, then a 19-year-old just drops dead. They go into VFib or VTAC, and if nobody shocks them out, then they obviously die. That looks like right bundle branch block, so like in V1, it has an S wave at the very end, and it's wide, and then it kind of just maintains this down sloping ST elevation. The other stuff is going to be your ventricular rhythms. Obviously, a wide QRS is going to produce ST changes. Raised ICP, if it's subarachnoid hemorrhage, can cause just these small little ST elevations, kind of widespread, like pericarditis. If it's other types of raised ICP, it causes these really large T-wave inversions in V1, V2, and V3, and you can have some residual issues with the ST segment because of that. And then, like always, hyperkalemia can cause ST elevation. The biggest learning point for hyperkalemia and ST elevation is if it's hyperkalemia with right axis deviation. If it's ST elevation with right axis deviation, it's more likely to be hyperkalemia as opposed to STEMI. STEMI usually is going to either have a normal axis or left axis deviation. ST depression. So first and foremost, myocardial ischemia can cause ST depression. First thing you should be thinking about though is this a reciprocal change? So if I have ST depression in lead 3, opposite of that lead reciprocally would be lead AVL. So if I have depression lead 3, I would scrutinize AVL for any ST elevation, looking for like a subtle lateral MI. Posterior MI produces ST depression T-wave inversions in lead 1, 2, 3, and 4, which is just a reciprocal change off of that posterior wall. Digoxin causes these little hockey stick type ST depression. It kind of looks like a hockey stick if I was a better artist. That doesn't mean they're digitoxic. That's just a common effect with digoxin. Hypokalemia, so in V1, V2, and V3. So if this is V2, it's common to have ST depression. And then after that, you have a U wave at the very end, which is a wave after the T wave. SVTs, just because they're beating so hard and fast, it causes some ischemia. So you'll notice ST depression with really fast heart rates. Bundle branches, because of the abnormal depolarization, causes abnormal repolarization. Hypertrophies, same thing, and then ventricular rhythm, same thing. T-wave inversion, it could be a infarction or a reciprocal change. Pulmonary embolism causes T-wave inversions in the inferior and right V leads, so 2, 3 AVF, and then V1, V2, and V3. There's this thing called persistent juvenile T-wave, which is, again, in usually younger African American males and females, where they just have these T waves that kind of look benign. So, like in V2, you have a little R wave, big S wave, and then you have just a little bit kind of dipping under at the very end. Or you'd have your little R wave, bigger S wave, little bitty T wave. Your bundle branch blocks cause abnormal repolarization along with ventricular hypertrophies. Hypertrophic cardiomyopathy is like a severe hypertrophy, essentially. I already talked about raised intracranial pressure causing T-wave inversions, and then pediatrics sometimes, until their heart kind of levels out, have these T waves in the septal and anterior leads. So that would be kind of the same thing as this persistent juvenile T wave, just in a pediatric. All right, just a few more differentials. Prolonged QT. This is probably my most interesting differential. This is where we did like our little poor man's QTC, and we drew our imaginary line, and the T wave ended after that imaginary line was. So what causes that would be hypokalemia, hypomagnesemia, hypocalcemia. Myocardial infarction is going to prolong the QT. Your raised intracranial pressure, if you have a really huge T-wave inversion, that's going to prolong the QT. Sodium channel blockers, hypothermia, and then some people just have congenital prolonged QT syndrome. Two of these are not like the others. So all of these make the T-wave really long. So you'll have QRS and then a really long T wave, which is a little bit exaggerated. Hypocalcemia and hypothermia cause QT prolongation because ST segment is really long with a normal T wave. So if you have a really long ST segment, you check a temperature and it's normal, and then you know they're hypocalcemic. There's also syncope, which I thought was on here. So what syncope means is anytime you run a patient that either passed out or nearly passed out, there's reasons to run a 12 lead. So syncope or first time seizure. So I know several times I've picked up people with syncope where bystanders are saying, hey, it was a seizure, and I'll ask them to describe it, and they'll be like, yeah, you know, like they started to fall over and they tensed up or they shook a little bit. A lot of times that's not seizure, that's just a normal response whenever the body loses blood pressure or for whatever reason. So syncope, I'm looking for tachy's. Kind of hard to type on or to write on this touchpad. Bradycardias, heart blocks. Those are the obvious ones. So if your heart's too fast, too slow, or if you're dropping a whole bunch of beats, it makes sense that you pass out because of that. The ones that are a little bit less intuitive are going to be that Rugata syndrome. Something called arrhythmogenic right ventricular dysplasia, which is kind of the same idea as Rugata, where it happens in young adults and causes sudden death if it's not identified and they get a pacemaker. Instead of Southeast Asian cultures, this is going to be in cultures originating from the Mediterranean. This looks like these big dagger type cuirasses. So there'd be these big dagger Q waves in the V leads. Aside from that, hypertrophic cardiomyopathy is the next major one. So just know there's a different term out there for syncope that just has to be memorized, and you have to figure out what those different pathologies look like. All right, so finally we're on to practice. So we just have to remember the order that we're going to go in. So rate rhythm, axis, intervals, enlargement, ischemia. So rate rhythm. So I'm going to find, get my little pin out. I'm going to find a QRS that lands on a bold line. So out here, let's say V6, this one lands on a bold line. 300, 150, 100, 75. So it ends before the 75. So this rate's about 80 beats a minute. Next, I'm going to try to determine what rhythm we're in. And it looks like we have positive P waves in all these leads except for AVR. And then normal looking P waves out in the V leads. So this would be normal sinus rhythm. So normal sinus rhythm at a rate of 80. We'll determine axis. So I'm going to find my most isoelectric lead or equiphasic, which this one is pointing all down for the most part. This one's pointing all up. This one's a little bit down, a little bit up, and then this one's mostly all up. So that leaves me AVF is about halfway up, halfway down. So AVF sits at 90. I'm going to look for my most positive lead, which I already said is 1. So the QRS axis is 90 degrees off of this isoelectric lead. So the axis is 0, which is normal axis. Next, we're going to look at our PR interval. So that looks to be 1, 2, 3, 4 boxes, which would be normal. Our QRS duration is less than 3, so that's normal. And then our QT, I just had an R to R, my imaginary line somewhere right there. My T wave ends before that. So we don't have any interval problems. All that is null. Look for enlargement. So AVL doesn't have a really big R wave, and it doesn't look like we have big enough S wave and R waves to call LVH. So this isn't LVH. I'll quickly look at B1, and this isn't right ventricular hypertrophy either. So that also is null. And then finally we get to ischemia. You just have to determine what way you like to look for ST deviations. So I'm going to go with the inferior leads first. So there's elevation here. There's depression in 3. There's depression in AVF. Look at the high lateral. I have elevation, elevation, and then my V leads, I just go in order V1 through V6. Isoelectric, ST elevation, clearly, sorry, it's out here. ST elevation is right here, ST elevation is right here, ST elevation. So I have a whole bunch of ST elevation with some ST depression. I'll also look at the T waves. Clearly there's huge T waves out in the V leads, and then T waves that are huge compared to the QRS out in lead 1 and AVL, and then T wave inversions down in 3 in AVF. So this would be a normal sinus rhythm at a rate of 80, normal axis, normal intervals, no enlargement, and a anterior lateral MI. All right, so I'll get out my pen again. And let's start with rate and rhythm. So again, I can just pick any lead. This one falls pretty much on a bold line. 300, 150, 100, 75, 60, 50. So this rate's between 50 and 60, so let's just call it 55. Look for my P waves. It looks like I have a normal P wave in lead 2, 1. They all look pretty normal to me. So this is just going to be sinus Brady at a rate of 55. So axis, I'm going to find whichever lead is most isoelectric or equiphasic. It looks like either 2 or AVF. 2 is the smallest lead, but AVF is a little bit more equal on each side. So let's just go with AVF. AVF sits at 90. Most positive lead is up here in lead 1. It sits at 0. So 90 degrees off of 90 is 0. So my axis is 0. So again, another normal axis. Look for intervals. My PR interval is normal. My QRS is 2.5 boxes, so that would be normal. And my QT is well below that cutoff. So that's null. I look for enlargement. So right here, it shows that I'm just borderline at 11 millimeters for an R wave and AVL. So this is possible LVH. Let's see if we have another criteria out there. So 4, 9, 14, 19 plus 20, 25, 30. So that doesn't cut it. And then this one's smaller. So I'm probably going to say this might be borderline LVH, but it's just below that cutoff criteria. So for now, we'll just call it null. And then finally, ischemia. Well, I have elevation down here in the inferior leads. I have a reciprocal change in AVL, not really anything in lead 1, then V1 through V6. I do not really have anything. I might have just a tiny bit of elevation out here in V6, but nothing that I would call lateral MI. This is just an isolated inferior MI. So sinus bradycardia, rate of 55, axis is normal, no interval problems, no enlargement, and an inferior MI. So the first thing I'd want to do is do a right-sided 12 lead to look to see if the RCA is the culprit. So that's what I would do here. So I would just switch all my leads, and this should be a little bit higher. V1 and V2 R should be in the actual fourth intercostal space. Whoever drew this actually made it a little bit lower than it needs to be. The main one that matters is V4R. V4R needs to be the main one that we place, because in, I think, 92% right ventricular MIs, V4R is going to show the elevation. I generally just put all my leads and I swap them over, because all you need to determine if it's a right ventricular MI is you just need elevation in one of these leads. There's also the posterior leads, which we talked about earlier. The placement for that is going to be V8. It's just going to be on the same level as V6, so the fifth intercostal space just below the scapula. V9 is in between V8 and the vertebral border, and then V7 is between V8 and V6. So this is what V4R would look like. Looks like they only switched over V4 to do a right-sided. This is ST depression, T-wave inversion in lead 2. So that's always a sign that it could be posterior. This also has a inferior MI as well. So this would be an inferior posterior MI. So this is an obvious case to look for right-sided involvement. They put V4R on, and all you need is 0.5 millimeter in the 0.5 millimeter whenever there's already an MI present on the 12 lead. If there was no inferior elevation or posterior STEMI, you would have to get a full millimeter in one of these leads to diagnose right ventricular MI. If you wanted to do a posterior, which if you had a 12 lead that had depression like this in V1, V2, and V3, you absolutely should. This also has a subtle inferior STEMI on it as well. Elevation in 2 and 3, or I mean 2 in AVF. Out here, we put on 7, 8, 9, and we have clear, huge ST elevation. There should be a caveat for this. The depression V1, V2, and V3 is more sensitive for posterior MI compared to the posterior leads, actually, because usually the posterior leads have to go through the entire lung tissue and bone and big muscle, so they'll have really small QRSs, so it's really hard to get 1 millimeter all the time. So no, if you just have this V1 through V3 look right here, that's usually enough to call it. All right, let's get back to doing our normal interpretation. So rate rhythm. So 300, 150, 100, 75. P waves are really small. Or actually, there's no P waves at all. So this is a junctional rhythm. Junctional rhythm at a rate of 75. So that would be an accelerated junctional rhythm, because junctional rhythm should be 40 to 60 beats per minute coming from the AV node. So this is an accelerated junctional rhythm, rate of 75. Axis, I'm going to look for the most isoelectric, which happens to be AVL. My most positive lead is lead 2. So 90 degrees off of negative 30 could either be negative 120 which would cause us to have a positive R wave or an R wave in AVR, which isn't present, or it could be 60, which is the case here since our R wave is present in E2. So that's a normal axis. So junctional. I don't think anybody can read what I just wrote. So junctional at a rate of 75. Axis is 60. Intervals, I don't have a PR, so ignore that. So I look for my QRS, which is 1 to 2.5. So just under wide QRS. QT looks normal. So our intervals are normal, excluding that absent PR interval. Enlargement, I don't have any signs of RVH or LVH. I don't have an atrial beat to tell if there's any left or right atrial enlargement. So that's null. And then finally, oh, actually, I missed something out here. I said in my enlargement section, I look for low voltage. Low voltage should be less than 5 millimeters in 1, 2, and 3. And that's present in all of them. So this is low voltage. And finally, ischemia. I look at my inferior leads first, which they all have T-wave inversions and mild ST depression. That clues me in that I should look immediately up to AVL for subtle ST elevation. And I think this might just be artifact. I would probably do some more 12 leads to look, but this looks isoelectric to me. Same thing, one probably has a little bit of ST depression. Lead 1, V1 doesn't have any elevation or depression. V2 has depression. V3 has depression. V4 has depression. V5, pretty isoelectric, but you can see where the T-wave is inverted. And same with 6. So I would start searching for a posterior MI because of the depression V2, V3, and sort of V4 if it had a bigger QRS. So this is probably a junctional rhythm, rate of 75, normal axis, normal intervals, low voltage, and a posterior MI. Skip a few till we find one that's more interesting. So we'll start from the beginning, rate rhythm. You'll find out here one that hopefully falls on a bold line, which none of them really perfectly do, but we'll say that this one's starting kind of close enough. So 300, 150, 100, 75. So probably right on the money at 75 beats a minute. So start looking for rhythm. I have some P waves out here. So commonly this would just be called normal sinus rhythm. Next we're going to do axis, which looks like AVL is isoelectric. AVL sits in 8 to 30. A2 is my most positive lead, so I've already memorized that, but this axis is 60 degrees, and that's within normal limits. Intervals. So I look at PR, and let me get rid of some of these. So I can see it a little bit better. So my PR starts right here, and my QRS starts right here. So that is a box and a half wide, which is less than my 120 milliseconds, which would be 3 boxes. So this is short PR. So now I need to reassess and determine if my diagnosis of normal sinus rhythm was correct. Normal sinus rhythm doesn't cause short PRs. So there's pretty much only one thing that causes that that we really care about, and that's going to be Wolff, Parkinson, White. So I'll keep going on with my assessment. Looks like we have a wide QRS, which is to be expected with Wolff Parkinson White. And then my QT looks normal, and before the arbitrary line. So I now have 75 beats a minute with Wolff Parkinson White, an axis of 60 intervals with a short PR. And now I need to look for LVH. I can't really. I do have criteria for LVH based off of V2 and V5, but I already have Wolff Parkinson White. So I can't really do that assessment anymore. And then finally, ST elevation. I do have ST elevation V1, V2, depression in V3, V4, V5, V6, along with depression in 2, 1, maybe AVF. None of it really matters because we already got WPW, which has a widened QRS and abnormal depolarization. So wide QRS causes abnormal repolarization. So you're going to have ST elevation and T wave that are opposite. So over here, abnormal depolarization, and then ST depression, T wave inversion. So this is kind of one of the examples where people can get really tripped up. I know a lot of people that have looked at this 12 lead and called it normal sinus rhythm with left bundle branch block, or maybe they didn't catch that it might be left bundle branch block due to a wide QRS, and they'll say it's normal sinus rhythm with a septal STEMI, which this patient's beating at 75 beats a minute. They probably don't even feel anything. They might feel some palpitations occasionally, but this isn't a tachycardia, so they're probably just sitting there hanging out. So if this happened out in the region and somebody identified this as ST elevation that they think is from STEMI, they could get a thrombolytic and end up dying from a bleed due to that thrombolytic, if only somebody would have caught that this was Wolff Parkinson White. So another telltale sign of Wolff Parkinson White, besides this PR being short and this wide QRS, is these delta waves. So a delta wave is a slurring of the upstroke of the QRS, which is present in all of these. Really hard to see whenever they're negative. So V1 and V2 are difficult to assess for. But out here in V5 and V6, you still see a little bit of slurring. Probably the best out here in Lead 1. All right, so here's the hardest EKG to really evaluate, especially for axis, but we'll go through it pretty slow. And it's really easier with patients because you're going to be able to get information either from them, from family, or from their presentation. So you get this 12 lead, immediately it looks abnormal and a little bit terrifying, but we're just going to start from the beginning. So I can't really tell where the QRS is easily, but I'll want to get a good rate to start with, and I know that there is something right here falling on a bold line, so 300, 150, 100. That means that this next little peak is sitting at about 140. So something's beating at 140 times a minute. I'm looking for rhythm, and I can't really tell what's going on. So this is just going to be wide complex tachycardia, so WCT for the time being. Next, we're going to look for axis. So in order to determine axis, we have to figure out where the QRS is. So I'm going to search for any lead that has something relatively looking like a QRS. And it looks like maybe V3 is that best lead. So my QRS kind of starts right here and probably ends somewhere right about here-ish. So now that I've marked at least one, I can move my cursor up and I can find, oh hey, V2 is not too hard to see. and then keep going up, and V1 out here. So you can use the leads that are in a column to determine the intervals that are present above them. And then to help figure out what's going on out here, I would just kind of start jumping backwards. So something like that, and then something like that. And then now I know my QRS is about this wide and all downward. And then I can move up. And this looks pretty isoelectric, maybe a little bit positive, and then keep going up. And I'm kind of getting off on my markings, but you can kind of see what I'm doing. AVR is all positive, and then I can kind of keep jumping backwards. And then lead 1, it's all negative. Lead 2, it's all negative. Lead 3 is all negative. So all my leads are negative except for AVL, which is isoelectric, and AVR, which is positive, whenever it comes to axis determination. My QRS is really wide. It's like 180 milliseconds. It might be 200. I have trouble determining exactly how wide it is because they're kind of all slurred together, but it's really wide. So we just go back to our axis determination. So we find our isoelectric lead, which is AVL. AVL sits at -30. We look for the most positive lead, which is AVR, which sits at -150 or 210 or whatever. So it's going to be 90 degrees off of -30, so -30 plus whatever minus 90 to get off of it would be -120 or positive 240. Yep. So that's in the extreme right axis deviation. So what happens out there is going to be either VTAC, hyper K, or extreme RVH. So again, I said you're going to have to couple all this with your patient assessment. So if my patient doesn't have a history of severe COPD or pulmonary embolism, then I'm going to get rid of RVH. And now I have to determine is it VTAC or hyperkalemia, which is two very different treatment patterns. Real quick, we'll just finish out. I can't determine any enlargement. I looked at intervals. I have a super wide QRS. I can't tell what my PR, I don't know what my QT really is. And then ischemia, there's elevation, depressions everywhere because of how wide the QRS complex is. So really what I got is I got a wide complex tachycardia with a rate of 140 with extreme RAD, so extreme right axis deviation. So if my patient's unconscious, then this gets really difficult. So I'm going to start searching for fistulas, medications, anything that might tell me, you know, do they have a history of renal failure, that sort of thing, or is this patient just, you know, a normal looking guy with no medical history, and is this VTAC? Because if it's VTAC, I'm going to shock them and give amiodarone. If it's hyperkalemia, I'm going to give calcium and start trying to get rid of that potassium. But if I give amiodarone to a hyperkalemic patient, it's going to send them into asystole potentially. And if you just shock a hyperkalemia patient, it's just going to do nothing essentially. Might wake them up if they have any level of awareness. So what you need to know about VTAC is VTAC usually has rates that are 160 and above, so 160 to 220-ish. 140 is kind of the cutoff, so we're kind of right on that line for this 12 lead. Slow VTAC, first thing you need to think is hyperkalemia, because calcium is a benign treatment. You can give a little calcium to somebody having VTAC, and it's not going to kill them. But if you give amiodarone to somebody having hyperkalemia, it absolutely has a high chance of killing them. So if I'm still on the fence, so if I don't have enough information, my patient's unconscious, then I'm just going to give a trial of calcium. And what that means is I give that trial calcium, I'm going to hit another 12 lead, and I'm going to see if my QRS narrowed at all. If it narrowed, then I'm going to keep giving calcium until I get them out of this rhythm. If it doesn't, then I might start considering shocking first and then starting an antidysrhythmic after that. All right, so we're running out a little bit of time, so this is our last section, and we're going to discuss Sgarbossa criteria, more specifically Smith's modified Sgarbossa criteria. So we use it to help find STEMI with a left bundle branch block, and we'll go over that criteria. So what is a normal bundle branch or a left bundle branch? That's whenever we have a widened QRS greater than 120 milliseconds or 0.12 seconds, which remember that's 3 little boxes wide. You're going to have a dominant S wave in V1, so that's kind of what people kind of were taught in school is you have V1. You're going to have a wide QRS, and then your T wave. So people said, hey, if you're traveling down a road this way and you're going until you hit your QRS, which way would you turn your blinker on? So if I'm going this way, I want to turn this way, that would be left. So that's a left bundle branch. So that's what a dominant S wave in V1 means. You shouldn't have T waves in V5, V6, and lead 1. And what's normal is your ST changes and T wave changes should be discordant, so opposite of the QRS deflection. So if the QRS is pointed downward, a wide QRS, you would expect there to be ST elevation and a positive T wave over here. Same thing's opposite is true. So if you have a positive wide QRS and it's the left bundle branch block, you'd expect to have T wave depression or ST depression and then T wave inversion. What would be abnormal is if I had this wide positive R wave, I had ST depression, and then I had a positive T wave, or I had a wide positive R wave, and I had and it didn't come down the baseline and I had ST elevation. That would be abnormal. So remember the phrase, abnormal depolarization causes abnormal repolarization. So left bundle branch block is a type of abnormal depolarization, so we're going to expect repolarization abnormalities opposite of that. All right, so here's a normal left bundle branch block. So I'm having this dominant S wave down here in lead V1. I have a wide QRS. I'm lacking Q waves out here in lead 1, V5, and V6. So that's just a normal left bundle branch block. So what I'm talking about with discordant changes is I have, all negative QRS, and then I have ST elevation, and I have a positive T wave, and the opposite's true. All R wave, ST depression, T wave inversion. So Sgarbossa, cardiologist, she came up with 3 criteria in the early 90s, I believe, which ended up being pretty decent. So concordant ST elevation, so concordant meaning on the same side as the QRS. So we were talking about normal discordant changes being opposite. Well, this is whenever the QRS is positive and you have ST elevation. So if you have that, that's concordant ST elevation. If you have it greater than 1 millimeter, that's criteria 1 for Sgarbossa. criteria 2 is concordant ST depression. So in leads V1, V2, and V3, you're always going to have a dominant S wave on a left bundle branch. So if you have that dominant S wave and then you have ST depression associated with that, that's Garbosa criteria 2. And then the third one, which was the least sensitive, was discordant ST elevation greater than 5 millimeters. So that means I have, you know, a wide QRS and then ST elevation that's over 5 millimeters, and then my T wave. So that's what she said was too much ST elevation. So it would be excessively discordant. If you have a paced rhythm that looks like left bundle branch block, which ends up being the case for most paced ventricular paced rhythms, this criteria also applies. So this is just what normal looks like on the left side. So you have discordant changes. So positive QRS, ST depression, T wave inversion to follow, or negative, mostly negative QRS, ST elevation, positive T wave. So different points of Garbosa criteria. So point 1 was this concordant ST elevation. All it has to be is in one lead. So one lead can have this ST elevation. So we have a positive QRS and then an ST elevation. So that's always going to be a sign of STEMI. Criteria 2 is this dominant S wave. So negative QRS with ST depression. Only has to be in one lead to meet her criteria, or ST elevation greater than 5 millimeters. So that turned out that that third one, that's greater than 5 millimeters, was causing a lot of false cath lab activations, as in they would go to cath lab because they had Garbosa criteria and there wouldn't be occlusion present. So Dr. Stephen Smith started coming up with a same set of criteria but a different third point. So instead of the 5 millimeters, he decided something else has to be done to identify which patients need to go to cath lab. So he said that you should compare the ST elevation to the depth of the preceding S wave, which is a typo in my PowerPoint. So we're going to compare, so kind of like what we did with the hyperacute T waves. We're going to measure how big the elevation is, and then we're going to divide it into the size of the QRS depth. So how that would look is if I have a QRS depth of 26 millimeters, and then I had ST elevation of, let's say, 7, I would measure this and it'd be 7. This would be 26. 7 divided by 26 equals 0.27, which is greater than the 25% cutoff, and that would be a reason to go to cath lab. All right, so does this one meet criteria? So I'm looking for, let's just start with this depression. So I'm looking for depression V1 greater than 1 millimeter. And it's kind of on the edge, but it's not fully 1 millimeter. V2 clearly has ST depression. I have one criteria. I can stop there, and this patient has a bundle branch block that needs to go to cath lab. But if you keep looking, it looks like I have concordant ST elevation, so I have a positive QRS with ST elevation. Same thing with V6. And then finally, I'm looking for any more concordant ST changes, which isn't present. Maybe out here. It's not really 1 millimeter though. And then the discordant changes. So this is 6 millimeters. My elevation is 5 millimeters. 5 divided by 6 is well over 25%. So this meets all 3 criteria. So criteria 1, criteria 2, and criteria 3. There's a little visual representation. So we have down and then up. So that's discordant, and it's excessively discordant. And then we had elevation that is concordant, and depression that is concordant as well. So this is a pace rhythm. Again, I'm just going to start over here in V1. Looks like I have a little bit of depression here, but not enough to say 1 millimeter. Absolutely huge amount of depression, V2, minimal in V3. So I already got one criteria. This needs to go to cath lab, but we can keep going. And it looks like I have excessively discordant ST elevation of V3. I have elevation of about 5 or 6, and then a QRS of about 5. So that's well over 25%. This patient needs to go to cath lab. So that's all it is. If you guys have any questions, please email me, give me a call, whatever you need to do. I can get you some more practice, some videos to watch, blogs to read on all of this. I know there's a whole lot to cover. We discussed, that there's something called Brugada syndrome and arrhythmogenic right ventricular dysplasia and hypertrophic cardiomyopathy. Each one of those would take, a 30-minute lecture. So you just have to get out there, learn what all those different things look like, and then get a lot of practice and ask questions whenever you need to. Thank you very much.